So I want to say that what I feel like is the health of the children and the community are reflecting many issues of the community as a whole, and particularly for Native communities, I think it really reflects colonization issues, and we'll get into understanding that as we go along. But to understand how to improve obesity and prevent obesity in communities, we need to understand these many layers that affect chronic disease. And I'm going to kind of just put some of these up. So when I'm teaching this to residents or families or people that want to understand, like, why is my child gaining weight? Why is my child large? I want to say that there are things that are sort of preventable and less preventable. And the less preventable stuff here really is the sort of hard to change stuff, the genetics, epigenetic stuff that happens prenatally. High birth weight, low birth weight, prematurity all affect later weight gain. Gestational diabetes, high risk for later weight gain. Smoking in pregnancy, we found at least a 1.3 to 1.4 increased risk of later obesity in mothers that smoked in pregnancy. Not breastfeeding, and then chronic early childhood illnesses such as asthma and lots of steroid bursts can all really affect early onset and significant obesity in children. Those things are more difficult to affect and to change, but need to be looked at. Some of the things I think we've been most working on are things like diet, changing diets, changing kids' exercise habits. Obviously, screen time is a big one. And then some other more newer things I think that we need to understand are stress and sleep. Children are not sleeping enough, and I'll show you some of my work on that later. And then medications. I had a number of kids on antipsychotic medications that gain large amounts of weight in short periods of time. And then I have a special interest in spectrum disorder children and their sensory processing issues, and those kids are often affected by overweight and obesity as well. Some of the critical pieces I've used in my research are trying to figure out how to use local data from local communities to promote action, long-term partnerships with many of the communities I work with, and what is our role as an academic in those partnerships, and how do we best be an ally for communities. We've talked a lot about community engagement and how to engage communities, and I'll just talk through that a little bit with my research. And then really using indigenous knowledge and indigenous constructs of health in order to design and form interventions together using community-driven solutions, some of which I'll talk about today. So when I first started, I have a couple of those grants that Alan was just mentioning, and I wanted to just mention that. I had a K23 grant, which is the physician's equivalent of a K01 or K08. And I got that at the same time as I got a smaller R grant under a NARCH grant. And that's a really nice mechanism to think about if there's NARCHs in your area that you can be a part of. This was an epidemiologic study, and we screened a number of children on 3 reservations in Wisconsin, which is where I was at the time. And we wanted to look at what the prevalence causes of pediatric obesity were. So we screened about almost 450 children, actually ages 3 to about 8. This is a subset of them, and you can see that the majority were overweight or obese. And of those children, we did actually cholestex on them, which Barbara talked about, which is a finger stick lipids, and we had 33% of them had cardiovascular risk factors, meaning they had either a high total cholesterol and a low HDL. And because these were not fasting, it's really hard to fast little people. So I didn't even bother trying. When you try to fast a 3-year-old, it just doesn't happen. So forget it right now. But compared to normal weight children that had almost none of these risk factors, and we looked at blood pressure in them and waist circumference and obviously BMI. And of those parents, about 75% of them were either overweight or obese. So that data was brought back to the communities, and we also took a look at I had many different students looking at the WIC charts of these children that we screened. And we went back in time to birth for each of these children, and you could see that the children really differ in how they changed in their growth depending on time. And you could see there's a couple of different periods of time when they really started to show differences in growth depending on where they were going to be, whether they were green, normal weight, yellow, which is the overweight category, or the red, which is the obese category later on at the time that we screened them. And that is that first kind of year of life is a very critical period of time, again, from many of those influences I talked about in that circular slide. And then again, it was kind of this toddler age period, kind of the 2.5 to 3 to 5-year-old period when the adiposity rebound is starting to occur. And we brought this data back to the communities, and we sat with each of the communities and showed them these growth patterns. And I really wanted to work prenatal and first year of life, and They just couldn't get their heads around that. So from then on, I really worked in that kind of toddler age group. So what I wanted to understand from people in the community was, how do people understand health? What do they define as a healthy child? What supports or hinders children from being healthy in the community? And then how do we partner together? Because a lot of the comments I got from that data that we showed was, well, how do we fix this? How do we work on this? And what do we think? And a lot of the WIC nurses were telling me that people were competing to have the 95th percentile babies because it sounded really good to have the baby at the 95th percentile, right? I didn't understand that. And there was also this concept of a fat baby is a healthy baby, because within ancestral memory, there was starvation and babies dying. And so a fat baby would have been one that would have survived. So it's really important to understand that historic concept. So we did a number of focus groups to try and understand, what are parents' perspectives on these reservations about? What are things that support or hinder, and what do they consider to be healthy children? And a lot of the things were really interesting and novel at the time. Now, this is back in about 2003. One of them was that safety was a really big concern. So if there were loose dogs in the community and people were worried about them, or what I call loose teenagers in the community that were running around, and parents didn't feel it was safe to have their kids outside, they would keep them inside. So that was good parenting, but it may not have been the healthiest thing in terms of biologically, but it was the healthiest for their safety in terms of being bitten or convinced to use drugs. So other factors were family factors, changing who's in the household, how crowded is the household, are people coming in and out of the household, how many people am I feeding, some self-efficacy issues, and then what kind of choices are there in the community for food? How far does it take to get to a decent grocery store that may have fruits or vegetables? So those are all important factors. We had family factors and community factors. So we used a number of different things to help engage the community in our first intervention design. We used these constructs of health. What do we think about health as a holistic concept? We got a lot of ideas about thinking about the whole child and the safety of the child, whether there were drugs and alcohol in the home, whether there was abuse, and whether there were good facilities and programs and food available. We used the WIC data I talked about. We used a lot of community input. We used data from our screenings. We used the evidence base and literature, and then we used what was in the environment to design the interventions with 3 communities. So my first intervention was a U01, which we didn't talk about that mechanism. And the U is a kind of a collaborative grant. It's basically an R, but the U stands for you're kind of getting together more often with your program officer. And I always used to joke with him that it was called You Do More Work because you have to talk to the program officer once a month. But we got to be really good friends. And Jared, I'm sure some of you will meet sometime, and he's still a very good friend of mine and has consulted with you guys. We'll consult with some of you. Since it's an NHLBI-funded CBPR work with 4 Wisconsin tribes, it was a 2-year RCT, and we did a family-based intervention with 2 to 5-year-old children. Again, looking at all of that data, we decided to focus on that age group with the community. We also set up community action boards to address local barriers to healthy lifestyles. Again, a separate topic I'm not going to discuss, but really those community action boards continue to meet. Many, many years later now, that study ended in 2005, and those action boards are all still meeting and all still making changes without any NIH or other funding, so that's been exciting. So the purpose of this study was to really look at what is an indigenous approach to health in terms of elders or mentors teaching life skills to the next generations. We had a number of different intervention materials, and you can see them kind of laid out on the table here. They ranged from books and leaflets about things to pedometers and videos about how to exercise, as well as this thing on the end, which is called the Move Cube, which is our most popular item still in my studies, which is a rollable cube that has different inserts you can put in it for either foods or activities or different kinds of things to do with children. And it is fairly indestructible, although we have had to replace a couple from some dog incidents. So here's just an example of one of the lessons and one of the little books. It was written by one of my mentors. This intervention actually was divided into 2 groups. The control group got a mailed intervention only, and the other group got home visitors bringing this intervention in. Intervention results, we had a total of 150 child-adult pairs on 4 Native communities in Wisconsin. we had 57% of the kids decrease their BMI from baseline, and 59% lost weight. Unfortunately, because the intervention group and the control group both did better compared to what was happening in the communities, we did not have a true control group, which is a very big trick in intervention trials in Native communities, where the community decided everybody needed to get something. So that was difficult, but really gave us a lot of insight in how to do this work. We had some, so here's the positive behavioral changes. But we did have increased fruit and vegetable intake in the intervention group compared to the control group, and decreased television watching, as well as self-efficacy for health behavior change, which were nice outcomes. Some of the participant comments, I think, were the most helpful to us. We had an open-ended questionnaire time, and we also did a lot of focus groups. And you can see that one of the things we got the most response from was the books that came into the home that were about these topics. So books about fruits and vegetable eating, books about exercise, all kinds of different kinds of books. And so Berenstain Bears Too Much TV, things like that were really helpful for people, that they didn't know there had been books about these things. We also found that the kids were able to mentor the parents and vice versa in terms of what was happening. So I'll just close with one of my favorite pictures from this study, which is a couple of kids in this age group eating apples at, guess what, the powwow. Yes. Don't usually see that, right? We're usually eating Indian tacos and things like that, right? All right. So from that study, we learned a lot about how to engage communities, how to recruit families, what kind of good intervention materials were, and we decided to do another study because I had so much requests for this study, and so many groups came up to me at different national conferences and said, we want this for our community, that we decided to expand it to a national trial. And we also expanded to 4 different, from 4 targets for the intervention to 2 more. We found in our dietary recalls for the children that they were up, a lot of them were up as late as 10, 11, 12 at night. Now these are, remember, 2 to 5-year-olds eating pizza, eating very, very late at night. And so we realized that not only were they eating too much because you add calories as you get, sort of eating late at night, but also that's a very stressful thing. Anybody that's had a 3-year-old up till midnight, you notice kind of they're not super well behaved. So that's going to increase stress in the family household, and so some of those routine things were really important. We also decided to focus directly on a direct mailed intervention because we were going to go nationally, and add Facebook and texting support as ways to support people. So we came up with the mailed-only intervention called the Wellness Journey, and then we actively designed an active control arm that was designed with 2 of our community partners called the Safety Journey, that focused on accident and injury prevention in the home and out of the home, because accidents and injuries are the leading cause of death in this age group. And so we felt like that was a good control and shouldn't affect weight gain. So here's the design. Or here's our partners, I'm sorry. This had the nomination that was in our first study, First Nations Community Health, which is an urban Indian clinic in Albuquerque, New Mexico, the Blackfeet Nation here in Montana, White Earth Nation in Minnesota, and Seneca Nation in upstate New York. So we had 3 time zones, which was quite tricky for arranging all of this. And again, funded by an NIH R01 out of NHLBI. These are our 6 healthy lifestyle targets. Be more active, reduce screen time, eat more fruits and vegetables, and drink less sugary beverages, eat less candy. Very similar to the first study, similar lessons with some modifications. For example, we had to do some modifications to the recipes for the broader diversity of tribal groups, but we also added this improving sleep habits and improving stress management. This was our approach model and the factors that we targeted. It's a socioecologic model targeting factors for the child, for the adult, the family home environment, and then social networking as our community component. This intervention did not include a community advisory board component, again, because we were so diversely spread out across the country. And here's the design. This is a kind of a unique design. We just had this published in Clinical Trials in January, where we had baseline assessments of the children, and then they were randomized by BMI percentile, so we had equal numbers of normal weight and overweight kids in each group, into either the wellness journey or the safety journey, and then at 12 months they crossed over. However, of course, you can't take away something you've already taught people, so the people who were in the wellness journey continued on with Facebook and texting for the next 12 months to see what the booster effect was going to be like. We had very good recruitment. We had 100% recruitment for the study. We had 450 families that we wanted to get into the study, and we actually were able to recruit all of those families. And we had attrition about 16% total overall. We're still waiting for the last, I think, 5 or 6 families from Blackfeet to finish up this month, so we're almost done. So the wellness toolkit, again, very similar to the last wellness toolkits. We did have a private Facebook site, and for those of you thinking about using Facebook, we learned a ton about this. What we learned was that Facebook is often used as a bullying tool on a lot of reservations. And so we had to create a private closed Facebook site that we monitored, and people often didn't post to it in the smaller communities. In the urban area, we had a lot more posting, a lot more sharing, where it was more anonymous. It was really interesting. But in the rural areas, and in both areas, it was a really great way of reaching people, because the text messaging, we often had dropped phones. People would change phones very frequently. It was hard to keep up with people, but people don't change their Facebook. So we could reach them and message them and get them to come in. So we had really good retention through the Facebook site. And people did a lot of lurking, which is looking but not posting. So that's how that worked. And here's, again, the refinement of the materials. A lot more input from the communities into getting these really tight now so that they're really well received. And because the books were so well received, we did put a book into every single lesson, so that over the course of the 2 years, there are 16 early literacy books is from about age 2 to 6 that go into the home. So there's a huge health literacy component that we've added, which is really nice. And here's some of the user comments. People liked reading the books and they were engaged with them. The mailed intervention, I think, has been so successful because people love getting things into the home. It comes directly in, it's addressed to the child, it creates a lot of excitement, and the whole family was able to interact with it. We only had 1 target child per family and 1 target adult per family, but obviously the whole family interacted with it. Here's some Facebook and texting, some of the sample things that we did. We had to add a lot of green chili recipes for New Mexico, which I hadn't had to do in the first study for mostly northern communities. And then we had the text messages that went into the home twice a week. And we got mostly good feedback about those, although I will say it was harder to keep up with people through that because we did have a lot of phone changes, and so that was a little bit more complicated. The outcome measures were BMI Z-score for children and caregiver BMI, and then we did a lot of surveys, and I'm still analyzing all of this survey data, as Vernon can attest to. We're working very hard on all of the data, and if anybody's interested in some of this data, come see me, because we have data. Demographics, you can see that this sample is primarily women volunteer for this sample. I think we had more women in this sample than in the first one. We had very significant income issues. You can see that 30% of our families are reporting less than $5,000 a year in income. So a very high, highly impoverished sample. Some college degree for about half of the sample, but I think that this was more significant than in our first study. Baseline weight status for the adults, we've been talking about this, so these are women mostly in their 30s, and you can see that the vast majority are either overweight or obese, with only 18% of them in the normal weight category. For the children, again, these are 2 to 5 year olds at baseline, and you can see that 60% are healthy, but 40% in that very young age group are overweight or obese. And I think someone else had a slide similar to this. This is the concern for childhood obesity risk, and this is not done by how heavy the child is, but just done overall. And you can see that most parents are completely unconcerned about this issue and don't see it as a problem. And I would say, as a treatment clinician, this is exactly what I saw in the clinic, that until kids are reaching 95th, 99th percentile, and usually middle school, parents have this perception that they're gonna grow out of it. And it's really only when it's really getting to be a really significant issue, or they're getting bullied or teased, do they come into the clinic, which is really sad because then a lot of times it's past the time that we can really do a lot. So looking at some of the non-modifiable risk factors at baseline, just to kind of show you some of these, you can see, and some of these are modifiable, I'm sorry. You can see that for sleep, we have, and the children who did not meet recommendations in most cases had worse modifiable risk factors, less sleep, more soda drinking, more TV, less active, etc., except for fruits and vegetable consumption was about equal. We did find in the study overall at baseline that these children are sleeping about an hour less than age norms. We don't understand all the reasons for that, but again, I think it's this sort of sleep schedules. And so we're still looking at that data and what that correlates with. It was not correlated with BMI. For the non-modifiable risk factors, the rural kids were the heavier kids. You can see the other ones sort of all go along, but were not significant in terms of gestational diabetes being reported to be native or having been breastfed. One of the most significant things that we found in this study was at baseline, again, I'm not talking about outcome data yet because it hasn't been discussed with the tribes, is food insecurity. We found very high rates of food insecurity in these communities. Like 61% of the families are answering yes to the 2 USDA food insecurity questions. And food insecurity was related to increasing levels of experienced stress. So this is a really significant problem. And there are different ways that different communities are dealing with it. We found it to be very different in urban versus rural areas. The urban areas are relying a lot more on food pantries, on donations, and other kinds of things, churches, etc. In the rural areas, people are relying much more on families, on bartering, on gathering, hunting, etc. So very different strategies, but still very high rates. The urban rates of food insecurity were much higher. You can see these are very different, rural versus urban, although they're both still very high. So I want to just conclude sort of that RCT just to talk about it a little bit as we're still finishing up all the data analysis. It is very challenging to run a 5-site RCT across the country at different communities. Each community had its own strengths and weaknesses. We had obviously the usual tribal council issues at 2 of the sites that delayed start of the sites by 2 years at 2 sites. Obesity is a very complex disorder, and I think BMI is also a very rough measure, particularly in young children, and it's tricky. This is a great target age group for forming habits, not so easy to show clear outcomes in because they're all at different points of time in the adiposity rebound. And there's also still a lot of early prenatal influences in this age group, so it's tricky. But I think, again, it's a really formative time, so it's a really important time. We did find that the families are really interested in change and really excited about being in the project. We had a lot of great, as I said, retention in the study. Nobody dropped out because they didn't like the study. The major dropouts were loss of child custody, moving out of the area were the 2 primary reasons for leaving the study. So I think to kind of conclude sort of broad strokes, and then I want to talk about some research gaps I see, is I really think that local community data can serve as a catalyst for change in communities. And I always agree with all the communities I work with that they will get their own data back. So each community has gotten each of their baseline data back for each of their communities. I almost never publish a particular individual community data because we usually aggregate it. In some cases, people want their particular community published, and then I'll work with them to do that, but primarily it's aggregated data. I think using both evidence-based approaches that we can bring as investigators, as well as getting this high level of community input, is really important. And then using and figuring out how do communities understand health, and how does that target change. And then I think we talked a lot about this yesterday, is that this long-term partnering piece, this trust-building piece, the sticking around piece, as well as figuring out what else you can offer the community besides just the intervention piece, are really, really crucial to doing this work. And I tell you, I learned the most that I've ever learned from communities by just going and listening, but also when I go up and volunteer. I used to go up and volunteer at 3 of the communities to be the Head Start doctor for like, you know, do 60 Head Start physicals in 3 days and take med students up with me. And I just saw just so much and learned so much from that and was able to give that back. So those are kind of really important pieces for you to think about. What's your give back if you're not a doc? So some of the research gaps that I see, and we talked a little bit about this last summer at the NHLBI meetings, is sleep. Understanding the important and critical role of sleep, both for adults and for children. Anybody that stayed up, you know, late studying for exams knows that when you stay up late, what do? You eat, right? And that keeps you awake because chewing actually is activating to your brain. So I work with a lot of kids in my pediatric weight management clinic about sleep management because a lot of them were gamers and they were staying up till 1 or 2 a.m. gaming and they were eating the whole time. I'm like, well, this isn't exercise and this is not exercise. So it was a problem. And stress. I think we've just begun to understand the huge role of stress and adverse childhood experiences in obesity and in, again, driving both hormonally induced changes, brain changes, as well as just in comfort eating. Food insecurity, I've touched on that today. I think that's a huge area for to be thinking about, to be looking at, as well as food deserts and how do communities really mobilize around creating their own food systems. These prenatal influences, I think, we're gonna find out more and more about how important these are. Particularly weight gain in pregnancy is a significant one. The role of toxins, PCBs and other toxins in plastics are starting to be shown to be associated with obesity, and lower income groups have often higher levels of those toxins. People have been talking about the gut microbiome. I think this is a really interesting and critical area. And lastly, something I've been working a lot on is community engagement and action, and how do we mobilize multiple facets of the community to work on changing the environment, to be more supportive of when families want to make changes, they're able to make those changes. And that's everything from engaging the police force and safety issues, to figuring out what sort of local policies can be changed, to figuring out how to change people's attitudes and ideas about local foods. So I'm going to conclude with Bucky Badger, sorry. But this is one of my favorite slides because it shows the entire Menominee Wellness team and my student at the time, who was a Bucky, who is now in medical school. And he came up and volunteered to be Bucky at one of our diabetes walks. So I just love that slide, sorry. And those are all my good friends from the Menominee Nation. And then this is one of my other students with one of our little participants. If you can sort of see it in the bottom, she's wearing an accelerometer belt before we had the watches. And you want to know anything about accelerometry belts in small people, let me know. It's a nightmare. But especially when they're potty training. Okay, we won't go there. Anyway, so that's Katie, and Katie's another one of my students, and she's now an internal medicine physician. And then I always want to thank the families and communities that participate, and that's one of our families at the Flambeau Powwow. Thank you.